Yeah, Bangladesh Society of Cardiovascular Intervention. We had two excellent sessions, one left main and another is how to prepare a bed. So my case is very simple. Interventionists know how to do, and they are perfect interventionists. They are very skilled. But one thing we should learn is when not to intervene. So this case is an interesting case, spontaneous coronary artery dissection presenting with acute coronary syndrome in a lady with antiphospholipid syndrome. So I'll be discussing this case and want to get feedback from our learned colleagues. So this is now it's a 41 years. She's non-smoker. She's married, had normal pregnancy, uncomplicated. She has a daughter now of 19 years. She had oral contraceptive for 13 years from 2001 to 2014. So I'll just go back to her history a little bit. She had a history of syncope in 2014. She consulted the neurosurgeons. They did cerebral angiograms. This is a picture here. And these are two pictures. What they've said is dural venous sinus thrombosis with thrombus in superior sagittal and cortical veins in the parietal region. And there's a hematoma of 3 into 3 into 1.6 centimeter in the right parietal lobe. This conforms with the cerebral venous sinus thrombosis. This is in 2014. So then she was advised for warfarin. She took warfarin for 2 years up to 2016. She stopped her oral contraceptive pills. And this lady did not have any features of SLE, livido reticularis, or deep vein thrombosis. After 2016, they did a cerebral angiogram. She was on warfarin. This repeat cerebral angiogram was normal. And she became default and stopped warfarin. In January 2019, she had a repeated hospital attendance emergency with a non-specific chest pain. Prior to this, 7 days and 10 days back, she attended the emergency department with chest pain. And that period of time, she had a non-specific chest pain. Her enzymes and ECGs were normal, which I'll show later. And in a week later, she presented with retrosternal heavy chest pain. Her counts were normal. Renal function was normal, and troponin this time was positive. This was a chest X-ray. And this was a ECG 7 days and 10 days back when she attended emergency. At that time, she was around 37, 38 years old lady. So this ECG was normal and her chest pain was vague symptoms. She was evaluated and was discharged from hospital as a non-specific or atypical chest pain. A week later, she attended emergency with this ECG. What we can see here is Q waves in V1, V2, V3, and ST elevations, and she has a typical chest pain. And this, if you compare with this ECG around 10 days or a week back, it's normal. So, and she was advised to undergo CT angiogram, because CT angiogram is relatively cheaper in my center and readily available. It costs around 8,000 Nepalese rupees. And what you can see here, CT angiogram is left main is normal, there's a circumflex is normal, and then LAD is occluded approximately. So as she had ongoing chest pain, then tropi was positive, ECG change was there. So we decided to do coronary angiogram in this patient's right was quite normal. And this is left pictures. So you see really, what you can see is diffuse disease of the LAD here. And this is what we can see here, multiple radiolucent saddle in the LAD and the diagonal branch, and circumflex is normal and right dominant. So my question now is, so if you look at this classification of spontaneous coronary artery dissections, this is a type 1, is the multiple radiolucent ligaments 1. Type 2 is a long diffuse lesions. A means if the vessels distal to this lesion is normal, then this A. If that extends distally, it's B. 3 is a focal lesions, which are very difficult to identify. It could be, it mimics like arthrosclerosis. And type 2 vessels are quite common. And somebody also classifies a type 4 SCAD if it's distally totally occluded. So this is a case of type 1 SCAD. Now my question is, how should I treat these patients? Should I treat with medical management? Should I treat with PCI? And CABG is out of question. So how should I treat these patients? So I would like to know from our panelists or experts.
Professor Hafiz, sir.
Is he here?
Probably left.
Okay.
So, Jamal, sir.
Yes. Then in the middle part, that is below the LED, there is a
Dr. Maski, would you go to the yes cranial view? Yeah, cranial.
This is the best pictures. What we can see is multiple radius markers. It's a type A dissections.
Cranial view, any?
Epicranial.
Epicranial, I did not put, I think. These are two pictures. And one first shot is not very clear.
Yes.
Yeah.
This one.
Epicranial, then we shall be able to evaluate the...
Yeah. This is epicranial. You can see here. Maybe a little underfill because it's not well placed.
So that this is an STEMI, yeah?
Yes.
No, this is a ACS.
ACS, but tropi was raised. There is
tropi was raised.
Q in B1 to
R wave is disappeared. Q from B1 to B3.
B3.
And ST elevation as well.
Some ST elevation in some.
So I think your first thing that you should do, you should take a good cranial view.
Yes.
I mean, if you go back and see this, you'll get the best pictures. These are the two best pictures you can see here. Distal. If you have to say distally, this is a distal filling system.
There is dissection, but I think it is crossable dissection. Just with the help of new wire, I think that lesion can be crossed because patient has got STEMI.
Yes.
Otherwise,
this is not STEMI. This is an STEMI.
Anyway.
This is acute coronary syndrome with non-ST elevation in eye.
Whatever. This is single vessel disease, and we should try to cross.
Second,
what about the clinical status?
Yeah, clinical status. About 7 to 10 days back, she came in the emergency and thought non-specific chest pain. Now she has complaints of chest pain with the ECG change and tropi is positive.
Echocardiography.
Echocardiography 45% EF, some mild hypokinesia of hereditary.
Here is the problem is that as it is a spontaneous dissection, then we have to also think about the underlying cause.
Antiphospholipid. Antiphospholipid.
At this period of time, we don't know anything about the patients. We after we evaluated the patients.
We shall have to manage the patient. I do agree with Dr. Ashok. Taking a floppy wire and we can take the chance to cross the LED.
Yes. I have got the plan B also, sir. If the patient is asymptomatic or mildly symptomatic, no failure, no chest pain, no further ECG change, and tropi is not raising further, then we can dual antiplatelet, anticoagulant. Then after 7 days, we relook the angiogram. I think that will be recanalized at that time. After 7 days, PCI will be more easier.
Not 7 days, after 14 days, it may be clear.
If there is a
sir, can I just I have experience of managing one of the cases like this in Chittagong. This patient have presented like non-ST elevation MI, and I managed this patient with heparin and followed by rivaroxaban, and patient conservatively really did well. And I searched the literature. They said you should tempt it to put a stand in this type of cases. Don't put the stand and keep your temptation. So not to put a stand because it may provoke much more hazard.
You should not be doing GP2V3 inhibitors or anticoagulation in patients if you think of SCAD. It's absolutely contraindicated.
Dr. Maski,
yes.
if it is a
non-ST elevation MI.
spontaneous
stable.
dissection giving rise to acute coronary syndrome. Do you think that this spontaneous dissection will heal spontaneously?
No, I'm coming to that point. So I just want to know from panel.
This is our question.
Sometimes it actually there is thrombus as well as spontaneous dissection as well as thrombus formation. So after thrombus resolution, the vessel will look better.
That is correct. But in my practice or in my clinical practice in life, I have seen several spontaneous dissection 3 months ago, 3 months later, 6 months later, it remains as it is. And most of all did not create acute coronary syndrome. But one case, I found that spontaneous dissection leading to acute myocardial infarction treated conservatively in a different center and then came to me. But I found that on angiogram that the spontaneous dissection. Similarly, like you, I told him to wait after 1 month, and after 1 month, I was ready for practically. I became ready for IVAS, and I was ready with IVAS. That dissection is as it is at the ostial part of the LAD, and by the IVAS, I have evaluated the case and I do angioplasty successfully.
Dr. Maski, can I say something? Can I say something here?
Yeah, I was looking for you.
Maski,
Okay, yes, I do.
The thing is that you see that the last week there is a state-of-the-art paper on SCAD in JAC intervention. So here it is it is like type 5 or something, like, because it's occlusive SCAD. So occlusive SCAD, you cannot keep in that, you cannot keep it like what Professor Mijamal was saying, that you cannot keep it like that. You have to go to intervene this one.
Yes.
Okay, so
Maski,
everybody.
Dr. Maski, please go ahead.
Maski
Okay.
also done,
Please
but
go
he
ahead,
is asking us.
So
Go ahead.
yeah. So what is the important is this slide is very important. So if you look at this, Jacqueline Shaw is a lady visiting a lot of SCADs in Canada. If you look at her this picture papers, which is published in 2019, 95% of this SCAD, after 30 days, they heal spontaneously. So we should not be very aggressive in dealing with these patients. So we should always think this is very important. But this patient had ACS, ongoing chest pain, Propi was both positive, and echo showing some mild LV dysfunctions. So should we do PCI in this patient? So what are the challenges? The technical difficulty is passing the guide wire and through lumen. If that guide wire passes into false lumen, there's hematoma extension and sideburns occlusion that becomes a disastrous. Even if you put a balloon, dilate or stain in those areas, there's a hematoma propagation and the chances of vessel loss of the vessel flow. And even if you put a stents, because these are hematoma would absorb in time, so there's a chances of stents malposition that may lead to stent thrombosis. So these are the challenges. And I've already mentioned earlier, if it goes into false lumen, then there's an iatrogenic dissection and there's a propagation of hematoma. If it goes proximally, then the risk of left main dissections is there. So you'll have to judge according to the patients. Well, and then other issue is IVUS and POCT is hard. The current recommendation is if the diagnosis is confirmed, you don't need to do any IVUS in these patients. But if there's a diagnostic uncertainty like a type 3 lesions, then you should do IVUS. The advantage is it will depict true and false chlorine lumen, extent of false lumen stent thrombosis, stent size and length. So what I do is we are not expert in doing IVUS and treating these patients. IVUS, pass the wire, pass the microcatheter and see the pressure. If the pressure is normal, then you are sure you are in the true lumen. So this is one technique which I follow. So pass the wire based on the clinical judgment. I will not say I'm right, but because patient has a chest pain, then I thought it was a case of ACS, passed the wire, dilated with a balloon. So this was dilated. And this is a picture here. So I do not see any landing zones. So I thought, okay, let's take a chance and put a long 3 × 48 stents covering the ostium of the LAD. So this is a same picture here. So this is a dilatations. And this is a picture here.
In a spontaneous dissection, it is better to give long stent because
Yeah,
it is very
no,
difficult to find out the line
I'm
zone.
coming to that points. I'll explain
thank
each
you.
and every points. So
It's very
what
good
we can see here is I put a long stents. I've occluded the diagonal ones.
Yeah, it's a very good decision.
So what is the stenting technique? I don't know anybody has this stenting technique, especially if you have a bifurcation lesions in LAD and D1. So I use a long stent covering the ostium of LAD. The principle is if you're putting stents, use the normal segments to normal segments. Do not leave any wide. Maybe you may have to cover at least 10 mm proximal or 10 mm distal. These are the saying. So what to do with this D1 stent? And this slide is very important. This is another by Joaquin Shaw and her team. So the recommendation of doing PCI is if the patient has ongoing ischemia, if the patient is in cardiogenic shock, if the patient is in sustained ventricular arrhythmias or left main dissection, these are clinical high risk features. In those cases, we have to do stenting in a patient with SCADs. And the high risk anatomies are left main, proximal LAD or multivessel spontaneous coronary artery dissections. And what is the stent strategy? Because they have hematomas. Some prefer just to do POVA. Some use a cutting balloon so that we can create a channel between false and true elements. And there are different stenting strategies. Some uses a long single stent. Others recommend that use the first ACE, then go to distal, then proximal, and then cover the middle ACE. Some says go from proximal to avoid retrograde extension, go distally, and some even recommend saying go sequentially, go distal, then proximal. So these are different stent strategies. So I prefer to use single stent strategy because it's easier and cheaper for us. So what about the post-PCI management? If you think of a SCAD, maybe they may be helpful of aspirin and some role of beta blockers. But in SCAD, because these are non-atherosclerotic lesions, so the role of ATP antagonists, ACI, ARV, statin, nitroglycerin, and calcium channel blockers are not proven. So this patient, I investigated and came out to be antiphospholipid syndrome. So I used triple therapy for 1 month, dual therapy, clopidogrel, warfarin 12 months, and season warfarin for last 1 year. And as a stent, so statin, ACI, beta blockers, and mineralocorticoid receptor antagonists are these are guideline-directed therapy. And did investigation of this lady. What is found here is the left renal artery thrombosis in this lady. In a patient with the SCAD, they are associated with fibromuscular dysplasia. 25 to 80% cases, they have fibromuscular dysplasia. Fibromuscular dysplasia is non-atherosclerotic, non-inflammatory vascular lesions. They affect the arterial beds, which can occur as stenosis, aneurysm, tortuosity, or dissections, and they involve renal, femoral, cerebral arteries. Here, cerebral and femoral arteries were normal, but there was a left renal artery thrombosis. And because this patient has cerebral venous thrombosis, I did a coagulation profile in these patients. The homocysteine protein C, S, cardiolipin, IgG, IgM antibodies, beta-2 glycoprotein, IgG, IgM antibodies, all are negative, except lupus-like anticoagulations. So the diagnostic criteria of antiphospholipid syndrome is you need to have one clinical criteria and one laboratory investigation. So this is a lady having cerebral venous thrombosis, left renal artery thrombosis. Those are cardiolipin and beta-2 glycoproteins when normal. She had lupus anticoagulants, which has persistently positive over 3 months. So this fulfills the criteria of cerebral venous thrombosis. One clinical criteria, that's the cerebral venous thrombosis. Another is renal artery thrombosis, and one laboratory criteria of lupus anticoagulant, which is persistently positive over 3 months. So this is a case of antiphospholipid syndrome, and this is a case of type 1 dissections with non-ST elevations in mind. So what is important is any lady less than 50 years, if they present with myocardial infarction and no traditional risk factors, then we should always think of spontaneous coronary artery dissections. So what is spontaneous coronary artery dissections? It's an acute development of false lumen within coronary artery wall, which compromises the coronary blood flow by external compression. The most important thing is they are not related to trauma, nor medical procedures, or they are non-atherosclerotics. And the mechanism is either they could be inside out, either due to intimal tear, or outside in because of hemorrhages in the vasa vasorum. So there's a hemorrhage into tunica media. So we do not know what is the exact mechanism, and the presentation mostly with chest pain and radiation to arm, and even they may present with the syncope or cardiac arrest in hardly a few cases. And we have seen a lot of cases coming up with patients with SCAD. So the clinical presentation may be complete absence of symptoms. It could be acute coronary syndrome, cardiogenic shock, cardiac arrest, or some even present with sudden cardiac arrest. In fact, if you go to literatures, the first lady who was described with spontaneous coronary artery syndrome was the lady has massive stretching, and they found the coronary artery syndrome, spontaneous coronary artery dissection in that first reported lady. So the predisposing factors are postpartum, fibromuscular dysplasia, connective tissue disorders, and hormone therapies. And the stresses are extreme physical exertion, emotional stress, Valsalva maneuvers like coughing, stretching, and vomitings. And indications are complete vessel occlusion in those patients presenting with STEMI. If there's a left main involvement, if ongoing ischemia, recurrent chest pain, hemodynamic instability, or sustained ventricular arrhythmias, then they are indicated for revascularization. Otherwise, I've already shown the conservative management is the treatment of choice, because 95% of the patients after 3 months, they recover. So my again question is, what would this lady would happen had I treated this patient conservatively and had done angiogram repeatedly after 2 months?
I think
There are a few literature saying antiphospholipid syndrome and acute myocardial infarction, especially in young. And the problem with antiphospholipid syndrome is they present with recurrent stent thrombosis. So in a patient with recurrent stent thrombosis, think of antiphospholipid syndrome. And the spontaneous coronary artery dissection antiphospholipid syndrome is commonly described in few literatures. So my take-home message is spontaneous coronary artery dissection should be considered in young women presenting with MI without traditional risk factors. Antiphospholipid can present as cerebral venous thrombosis. Most SCAD will heal spontaneously. Revascularization in SCAD is indicated only in subset of patients like left main involvement, STEMI, ongoing ischemia, or hemodynamic instability. SCAD presenting with antiphospholipid syndrome presenting as acute coronary syndrome is rare and management is challenging. Thank you.
Thank you very much, Dr. Maski. You have done a very good job and giving elaborate about the spontaneous coronary dissection. Thank you very much. So.